in thinking about health systems capacity and really the ability of clinicians and academic organizations to be involved with global health organizations and be involved in various parts of the world to build local capacity. She and Dr. Myers, who's our chief of urology, have been working on a new initiative, and I will turn the podium over to Dr. Kurtzman to tell us all about it and how she's thinking about it. So thank you.
Awesome. Well, thanks everybody for being here, and thanks to everyone that is logged in over Zoom. So as Dr. Jayaraman mentioned, I'm a current first-year fellow in reconstructive urology, and today I'm going to give my talk that I entitled From Assessment to Action, Early Experiences in Building the GU Impacts Program in Global Urology.
Wait, before you go to switch.
Oh, sorry.
Oh, that's fine. Actually, it's probably either way.
All right, I'll go ahead 1 second.
Great.
All right, so as Dr. Jayaraman mentioned, GU Impacts is a new urology initiative that I started here at the University of Utah with Dr. Myers, who's our division chief of urology last year. And even though we founded it here, it's actually designed to be a multi-institutional organization that is designed to provide needs-based support to low and middle income countries to increase capacity in urology. We currently have 2 program sites where we're working in partnership with the local national urologic associations there, the first in Rwanda, and the second, which is a new program in Cambodia. So the reason why I highlighted the word needs-based in here is because it was what I was hoping to focus on during this talk today. And I thought that there'd be a lot of medical students and PHs here to talk to you, so I wanted to sort of gear it, frame it in this way. And I was hoping that everyone who's here today could walk away with some understanding of what it means to be a needs-based program, why it's important, and how to do a needs assessment. I also wanted to share the results or some of the results of the needs assessment that we did in Cambodia, and then explain the structure of our GU Impacts program in each of our partner countries. So I decided that I wanted to start off with just some information about a place that we all know really well to kind of put into context some of the places that we're working. So the United States. So as many of you know, the United States is currently ranked 7th among 196 countries by the World Bank in terms of gross national income per capita. It's about 3.8 million square miles and approximately 2,700 miles coast to coast. According to the most recent data, the average household income is about $75,000 per year. So I don't think I can ask here over Zoom, but I guess in the audience, how many people live in the United States?
About 310 million.
Close. So most recently, when I made this talk, 332 million. And how many urologists do we think are actively practicing in the United States?
I'd say like 1 per 100,000. No, that's slow.
So about 14,000 as of the statistics gathered by the census of 2022. So you're getting at what I'm trying to show, which is that there's about 4 urologists per 100,000 people in the United States, or 42 urologists for every 1 million people. So let's talk about Cambodia. Cambodia, much unlike the United States, is ranked 152nd among those 196 countries, putting it in the bottom 25%. It's about 70,000 square miles, or about the size of the state of Missouri. And the average annual household income there is about $1,540 per year. How many people live in Cambodia? That might be a harder question.
7 million.
All right, a lot more than that, 16.6 million these days. And how many urologists do we think there are in Cambodia?
In the whole country?
It might be more than you think.
I'd say still maybe 1 urologist for every 250,000 people.
Okay, I'd say that's a pretty good guess. So there's about 80 practicing urologists as of, my visit there and conversations with the Urologic Association there. So that's about half a urologist for every 100,000 people, or about 5 urologists for every 1 million people. So sort of to compare that or make that palatable for people, I said it's about the same landmass as the state of Missouri, which currently in Missouri, there's about 4 urologists for every 100,000 people, or 40 for every 1 million. So about 10 times as many in the same landmass in Missouri than there are in Cambodia. And what about Rwanda? Rwanda ranks 173rd in terms of GNI per capita, 19 ranks below Cambodia. It's much smaller, 10,000 square miles, about the size of the state of Massachusetts. And the annual household income is only about $1,000 per year. Now, how many people live in Rwanda? I won't make you guess, but I think that
1 million.
13.5 million, according to the most recent Google search I did. And how many urologists are there in Cambodia?
Oh, Rwanda.
I'm sorry, in Rwanda.
6.
13 as of December 31st of 2023.
I like this quiz. These talks.
All right. So what does that equate to? Less than 0.1 urologists per 100,000 people, or less than 1 urologist for every 1 million people. Sort of equating that to what you see in the similar sized landmass of Massachusetts. There's about 6 urologists for every 100,000, or 60 urologists per 1 million. So why do we care about urology at all? And this was sort of geared for medical students who maybe haven't had any experience in urology or even know what we really do. So a lot of the times when people hear urology, they just think that we're the penis doctors, we're the testicle doctors, and we're the people taking care of the prostates. But actually, urologists are the surgeons for the kidneys, for the ureter, for the bladder, for the prostate, for the urethra, for the testicles, and for the penis. And so what that means in terms of vital organ systems is that urologists are the surgeons for 2 of the 9 vital organ systems in the body. And what that means is that when patients with surgical diseases that affect their urologic organs lack access to urologic care, there can be a risk of vital organ failure, which, especially in low resource and low income environments, can lead to early death. So according to the 2015 Lancet Commission on Global Surgery, it's estimated that about 5 billion people lack access to safe and affordable surgical care, and that 143 million additional surgeries are needed to save lives and prevent disability due to surgical disease. Of course, one way that you could address this issue would be to increase the number of surgeons around the globe. But unfortunately, we can't single-handedly control that. But what we can do is work towards increasing the knowledge, experience, and skills of surgeons who are already working around the globe in order to improve patient access to safe and affordable surgical care. Another way of saying this is that we can work towards increasing surgical capacity in places of need. So how do we know what experiences, knowledge, and skills local providers need to learn in order to best serve their patients? And that's where this concept of a needs assessment comes in, which I'm going to spend a few minutes sort of talking about in the next few slides. So a needs assessment is a systematic process for determining and addressing needs or gaps between current conditions and desired conditions or wants. The goal of the needs assessment, especially when you're talking about a global health program or global surgery program, as I am, is ideally to match a country's educational and clinical needs and resources with the educational and clinical support and instruction that the program is going to be designed to offer. The other goal of the needs assessment is to help deliver training in a way that is both safe and within the limits of what is feasible in a resource-constrained environment. Even though we all want to be able to teach others to do things our way is not always the safest way in resource-limited countries. I use an example here of something that we do in reconstructive urology called a colon pouch. And this is a surgery that we do to make a new bladder out of intestines for patients who need their bladders removed. It's like the Cadillac of bladder reconstructions, but the patient needs to have knowledge and resources in order to manage it safely. The patient has to be able to catheterize themselves through a channel that we create in their belly button, and they have to be able to do this multiple times a day. Because of the way that we make it, if they're not able to catheterize, they can have catastrophic outcomes. A patient who can't cath can end up in retention. They might not be able to then catheterize because of the way the channel gets blocked. Acid from the urine can get reabsorbed by the intestinal lining of this new pouch. The kidneys get obstructed, and the patients can develop severe metabolic acidosis relatively quickly and end up in very, very devastating clinical states. In a place like Rwanda, where straight catheters are prohibitively expensive and patients don't readily have access to them, teaching surgeons how to do colon pouches as a primary way of diverting urine may not be the safest thing to focus on. And instead, we'd like to focus in teaching efforts on other ways of diverting urine that might be more safe for patients. So that sort of brings me to my last point about the purpose of a needs assessment, which is to make sure that what we're actually achieving is what we set out to do. And Dr. Derma Tafara, who's the current medical director of Operation Giving Back, the global surgery arm of the American College of Surgery, famously said in a talk, there is a difference between feeling good and doing good. And I bring this up here because I think a needs assessment is the foundation of that principle. You can feel good just by participating in global health work and feeling like you're making a difference, but you can only really know that you're doing good if you actually know what is needed and you know that you're working towards meeting that need. So how do you do a needs assessment? This is a question that I had when I first came here and I first, started to think about where to start with this new urology initiative. And so I'm going to share with you what I've sort of learned. And some of it may seem a little bit simple, but I think it's important to say out loud. So aside from having an idea for what you want your program to focus on, I think the first step is really to build relationships with local providers in clinical areas of interest. Ideally, that person works in the public system. Ideally, they're involved in some form of resident or medical education. And ideally, that person maybe has a leadership role or at least participates in their national specialty society. This sort of allows you to have a connection locally with somebody that you could actually work with to make a difference in the education system. The other part is to actually plan to physically travel to that location of interest and actually perform the assessment. I was an anthropology major in college, and we talked a lot about armchair anthropologists. And I think that in the world of global surgery and global health, it's very similar. It's important to not be an armchair global health person. You actually have to go see and experience sort of the environment that you're going to be working in. So when I'm thinking about needs assessments now, I sort of structure them in my head as what I'm referring to as like an informal needs assessment versus a more formal one. An informal one for me is sort of just being there, talking to people, getting around, interviewing providers, administrative leadership, setting up meetings, maybe going on tours, shadowing, rounding on inpatients, getting a sense of how things work. And then in my mind, a more formal needs assessment is sort of everything I described as the informal part, but also using some form of tool to standardize your assessment and actually collect data so you can go back and look at it and present it. So in terms of tools, the WHO does have a needs assessment tool for general surgery, but nothing like it exists for urology. So as part of the initial sort of part of this project, we needed to design one ourselves. So I spent some time trying to figure out how you do that. And I think my biggest takeaway is that in order to design a needs assessment tool, the most important thing is that you need to set your objective for the tool. So I started off by first defining the overall purpose of the assessment. And the purpose of the assessment and the tool in our case was to use the data that we gathered to design a targeted multimodal training program for practicing urologists that we wanted to be designed to specifically improve surgical capacity and competency in areas of greatest need while remaining sensitive to the realities of site-specific resource limitations and patient safety issues, and with the goal of improving care in a way that is both safe and sustainable. And I use this sort of mission statement to formulate the sections of our needs assessment. So then the next step, of course, is to kind of define the actual goals of the assessment at each hospital or each location that you might visit, which I think can be categorized into a couple of different categories. The first being demographics. Who are the patients? Who are the providers? How do patients access care? What are some barriers that patients might have to accessing care? And what type of training do the providers get? Which sort of gets into surgical competency. What are the providers trained to do? What do they have resources to be able to do? And sort of what is the expanse of their surgical knowledge and also their surgical ability? Scope of care. What are patients coming in with? What are their problems? What are their pathologies? What are their presentations? What do providers struggle with in terms of diagnosing these patients or treating these patients? Record keeping and research. So I think this is a big topic that I didn't realize at first, but is incredibly important, which is how do providers track patients? Do they have record keeping? Can they look back at their outcomes and kind of know what's going on in their surgical cases or not? And then resources and services. So by that, I mean like access to microbiology labs, access to catheters, access to actual equipment that we would normally use in cases in the OR, and then services. By that, I mean radiology services, blood transfusion, dialysis, things that we maybe take for granted here in the United States, but you really have to assess in a new location. And then these all sort of topics that I mentioned kind of hit on these 5 A's of access to care, which is affordability, availability, accessibility, accommodation, and acceptability. So those are sort of the premises that you want to make sure that you touch on in terms of patient access. So our needs assessment tool is a very long tool. It's about 24 pages, I would say, but a lot of it is the multiple choice drop-down menu. So it's not actually that long, but it's specific to urology. It's the first of its kind to my knowledge, and it's designed to be used in a low and middle income country setting. And these are sort of all the categories that it covers. So it covers things from sort of the general hospital infrastructure, the patient demographics, as I mentioned, to urology patient needs, access to resources, national urologist demographics, and then things like workshop feasibility, equipment, sterilization, rules about international donation, things like that. So as I mentioned, we have now two sort of partnerships, one in Rwanda and one in Cambodia. The partnership in Rwanda was sort of pre-existing prior to GU Impacts because of work that Dr. Myers had been doing there. So we did an informal needs assessment in November of 2023, but in Cambodia, we did a more formal needs assessment in February of this year. And in Cambodia is where we first piloted the urology needs assessment tool. So I'm going to kind of quickly give you a couple of takeaways from the Cambodia needs assessment. So this needs assessment happened at the end of January, beginning of February. Currently in Cambodia, there are 7 public hospitals in the entire country that deliver urology care. And the needs assessment was conducted at 6 of the 7 hospitals. The one hospital where it didn't go was one hospital which has a relatively new urology program and only about 2 providers that are kind of there part-time. So the couple of things I'm just going to kind of point to are our results regarding access to urology care, most common pathology, hospital resource needs, patient resources, access and needs, their greatest area of sort of training need and research support. I should say that in Cambodia, this needs assessment was focused on adult urology because their pediatric urology occurs in a separate hospital systems. And so this was all adult focused and not focused on pediatric. So in terms of patient access to urology care, I think you have to know how the system works in the country that you want to start a program in order to know where you should be working. So in Cambodia, they have basically a 3-tiered insurance system. They have patients who have private insurance or they pay out of pocket. These tend to be the more wealthy patients. They have patients who are in a government subsidized insurance system that pay about $3 per month per person, or they have patients that are enrolled in a free healthcare system. And this is for patients that qualify as very poor and they have no financial obligations. Public hospitals care, in fact, for all insurance types. And insurance type really just plays a role in sort of what sort of location, hospital bed room you get in the hospital. Most of the hospital-based urologists in Cambodia are located in the capital. Of those 7 hospitals with urologists, 4 of them are in Phnom Penh, and those 4 hospitals are the teaching hospitals where residents rotate through. So here's sort of a map with a distribution of where those hospitals are. So you can see there's a huge swath of territory in eastern Cambodia where there are no hospital-based urologists. One thing that I think is an important takeaway, though, is that even though there are 7 hospitals, as I kind of demonstrate here, not all public hospitals are created equally. And this really came through at the needs assessment that we did at this one hospital pictured on the left, which was located in a relatively rural province with 1 urologist. There, as all the other public hospitals, will treat patients that are in the poor uninsured category. But unfortunately, because of their lack of physical resources, patients can't get things done like a urine culture because there is no microbiology lab. So for a patient to have a simple study like that, they either have to pay out of pocket and then the government has to reimburse the hospital later, or the patient has the option of being transferred down to a hospital in the capital city where there is a lab and the services can be rendered for free from the start. So what that means is that lots of these patients that are seen sort of in provinces and hospitals outside of the capital city end up getting their care in the capital city, where there are these 3 large public hospitals delivering a lot of the care. And what this also shows, or sort of taught us in the needs assessment, was that should be the primary focus of where we do our training, is that the hospitals where most patients ultimately end up for their urology care. So in terms of common pathologies, the 2 most common pathologies were kidney stones and BPH, followed by urinary retention, urologic trauma, and cancers. Just a quick note about cancers. Unfortunately, most of the cancers that they see are metastatic on presentation and very infrequently operative. There also are some, and this could be an entire talk in and of itself, but there are some psycho-religio social barriers to surgery in patients that are not metastatic, in part having to do with the cultural and political history of Cambodia, where patients that are of an older generation survived a mass genocide and maybe have some different perceptions about death and dying than maybe we do in a country where that hasn't happened. And then also religiously, Buddhism really does play into how people make decisions about their care. In terms of hospital resource needs, I'd say the primary needs that we identified were a need for flexible cystoscopes, a need for PCNL or minimally invasive stone equipment, primarily at this one big provincial hospital that services about 800,000 people, where all of the urologists are in fact trained in how to do minimally invasive stone surgery, but they don't have access to any equipment. So instead, they're doing a very outdated procedure that we stopped doing about 40 years ago in the United States, where we do a major abdominal surgery, open up the kidney, slice it in half, and take out the stones. And this was just very interesting to learn that the surgeons are skilled and trained to do this, but because of a lack of resources, 5 to 8 patients a week at this one hospital are getting open stone surgery. And then the other sort of missing element that hospitals really need support for is in developing some form of medical record keeping system. Only one hospital had a real EMR. In terms of patient resources, patients do have easy access to Foley catheters. Similar to Rwanda, they basically have no access to straight catheters. And they do have access to things like urostomy bags, though they are difficult and expensive to access, but they are available in the country. So getting to kind of the crux of, the needs assessment or what they need in terms of sort of training was interestingly assistance in urethral reconstruction, specifically something we call posterior urethroplasty in urology. And this is a surgery that we do for patients that have injuries to the urethra during trauma, primarily during pelvic fracture injury. The urethra sort of shears off the prostate, and you end up with a blockage there. And in Cambodia, no one knew really what the incidence was there, but after going around and doing this needs assessment, it seems that there's about 5 to 8 cases per month that are presenting to the 3 teaching hospitals in the capital city, which for context, a hospital is very busy in the United States at fixing these type of injuries if they're doing about 10 or 12 per year. So in a country like this, they're getting about 60 to 100 injuries per year. Unfortunately, there's only one person in the entire country who has any training in how to repair these injuries, and his training was 3 months of an observership in India. So he's really looking for help in treating these about 80 to 100 patients per year that have no option for surgery at this time. So what they need in terms of how to do this and how to do it correctly is diagnostic imaging, help with radiology imaging, because their radiology services don't know how to do the imaging that you need in order to help diagnose these injuries. They need help with understanding clinical decision-making, and then, of course, the actual surgical skill and management of complications. I put in here in kind of italics and light gray, because this is not a primary need, but it is something that was expressed at all of the hospitals, which is need for laparoscopic nephrectomy training. And this is not because laparoscopic nephrectomy is just like a sexy thing to do, which is what some people think, but actually it's because they are planning and working in partnership with France on building at least one transplant program in the country. And in kidney transplant, if you are starting a program, you have to start a live donor program first. And it's a very hard sell to do an open nephrectomy on a live donor in 2024. So a laparoscopic nephrectomy is, if you can get good at them on cancer patients, you can actually help sort of build the capacity you need in order to then offer transplant programs in the future. And then in terms of research, so database system for tracking patient outcomes in order to demonstrate their outcomes to community-based urologists was something that was very much expressed and identified in this needs assessment. And then help with designing and publishing local research in order to demonstrate sort of local disease pathology and presentations to similar low-middle income countries. So I don't know where I'm doing on time. I guess I'm okay. Okay. All right. Sorry. So as I mentioned, so we have now sort of these 2 partnerships, one in Cambodia, one in Rwanda. The Rwanda partnership is with the Urologic Association there. There we sort of agreed on 2 programs, each are 5 years. And these sort of program focuses were based on the informal needs assessment, which I didn't get into detail about, but there's an adult reconstructive urology program that is focused on complex urethral reconstruction, and a plan for a pediatric urology program, hopefully to start next year, that's focused on hypospadias and bladder exstrophy. And then in Cambodia, we have a partnership now with the Cambodian Urologic Association. And this program is, again, 5 years. And it's focused primarily on, as I mentioned, adult urethral injury repair. And we're going to start sort of moving forward with that at the end of this year. So in terms of sort of the structure of the GU Impacts program in general, which I'm just going to quickly touch on, it's relatively similar in both of these countries in that we are sort of three-pronged. One is surgical skills and resources. The next prong is sort of what I call knowledge transfer and consultation. And the third part is outcomes measures and research support. So the way each program is implemented at each of our sites is we are assembling a team of volunteer expert urologists who are committing to being part of what we're calling a core faculty team for each program. These team members commit to the program for its entire duration, so the 5-year duration, and they commit to participating in surgical workshops and the virtual education piece of the program. They also commit to traveling to the partner country at least once per year to host a hands-on, very focused surgical workshop throughout the duration of the commitment. And these surgical workshops are being similarly sort of designed in Cambodia and in Rwanda, where they're focused on those topics that I mentioned. Index patients are collected in advance by local providers. Cases are presented and reviewed when able over Zoom a couple of weeks before in order to help with planning for the workshops and any additional preoperative testing that might be done. Patients are then seen in person in a preoperative clinic in combination with the local providers, the residents, and the core faculty team. Cases are discussed after the clinic and a surgical program is made for the week. The surgical program takes place at hospitals only with trainees, so teaching hospitals in both locations. Post-operatively, we are tracking outcomes from surgeries that are being done during workshops, and patient follow-up is being presented about 3 months afterwards in Zoom meetings where all team members are present. We have our first one coming up from the November trip in a couple of weeks. Patients with complications that are presented that had occurred in relation to a workshop are being prioritized if necessary and if feasible for upcoming workshops. So the GU Impacts sort of Rwanda adult reconstructive urology team is currently these 5 people. We are in the process of recruiting one additional person, and each of these providers that I've mentioned have committed to partnership and traveling to these countries traveling to Rwanda to provide surgical workshops once per year, which equates to about every 4 months for the next 5 years. Our pediatrics urology program in Rwanda is somewhat in the works and is actually awaiting a focused needs assessment just for bladder exstrophy care because it's a very complex topic in and of itself. And then our GU Impacts Cambodia team is currently also in the works. So far, I'm part of the team as well as Dr. McCormick, and we have some meetings this week to recruit some additional faculty members from other institutions. In terms of knowledge transfer and consultation, so all of our GU Impacts team members agreed to participate in virtual education conferences, which are not too frequent, only about every 3 to 4 months, and given in 2 formats, either a grand rounds or educational format or an indication conference where local providers are given the opportunity to present complex patients to their core faculty teams for expert advice about diagnosis and management. And then research, part of this program, as I mentioned, is designed to provide some support for designing research protocols and database creation locally with our partners and things like statistical support and English writing support. We had our first sort of abstract accepted to the American Urologic Association for a podium presentation this May from a project that we worked on with the team in Rwanda. So in terms of our next steps, so we have our upcoming Rwanda Adult Recon Workshop in April. The remaining ones are planned for September and November of this year. The first Cambodia workshop is probably going to be in October. We're working on recruiting additional members for our Cambodia and Rwanda PEDS teams. We're filing for a 501c3 designation for our organization. We're working on applying for some grant funding, and we are working on designing and piloting a database system for tracking our workshop patients. So that's sort of where we are and what I wanted to share, and I'm open to any questions, comments, or feedback.